Neuroendocrine tumors, or NETs, can be very difficult to diagnose. Quite often, NETs are missed for 5 to 7 years before being correctly diagnosed and treated. I'm Richard Oldham for the NET Report. In our previous reports, we asked what neuroendocrine tumors are and why they're often mistaken for irritable bowel syndrome. In coming segments, we'll look at how patients adapt to living with NETs and why doctors in several specialties are involved in treating this serious condition. Today we're speaking to experts about the tests to confirm the diagnosis of NETs and procedures available to manage them. We asked Dr. Simron Singh and Dr. Eugene Waltering why it's so difficult to diagnose a NET.
A neuroendocrine tumor is a unique and uncommon type of tumor. It's basically a tumor that arrives from neural cells anywhere throughout the body. The most common sites for a neuroendocrine tumor to be found in the body is along the GI tract, the small bowel, the intestine, the rectum, but really it can occur anywhere throughout the GI tract, including the pancreas and also in the lung. Neuroendocrine tumors aren't well understood, I think, or commonly known by the medical community, and that causes a lot of problems in terms of diagnosis. Often, by the time a patient reaches me, they've seen multiple doctors and have spent sometimes up to years trying to explore different opinions to try to come to a conclusion about why they're having the symptoms that they are.
In medical school, we're taught that common things are common. If you hear a hoofbeat, there's always a horse around. But occasionally, if you hear a hoofbeat, it's not a horse, it's a zebra. And that's what these neuroendocrine tumors are called, are the zebras of the tumor world, and the fact that they often their diagnosis will be triggered by a specific syndrome or a specific symptom.
There's a wide variety of symptoms that someone with a neuroendocrine tumor can experience. They can range from very generalized symptoms like abdominal pain, nausea, even vomiting, to feeling unwell, to much more specific symptoms like flushing, multiple times a day often, diarrhea, wheezing, or what we call bronchospasm.
If a NET is suspected by your doctor, diagnosis will be based on a combination of the type of symptoms present, the results of special blood and urine tests, and the characteristics of the tumor if one has been detected. A characteristic of NET cells is their ability to produce and release certain proteins or markers into the bloodstream. Among these is serotonin, which can be responsible for many of the symptoms associated with NETs. Another is chromogranin A, which is produced and released by up to 90% of NETs. Other markers are detectable for only certain types of NETs. These include neuronal-specific enolase and pancreatic polypeptide.
These tumors do secrete peptides, hormones, amines that might be elevated in the blood. Some are seen only in patients who have symptoms, for instance, gastrin, insulin, serotonin. Others are secreted by all NETs and should be a marker of NET in the blood. And the main substance here, secreted by the vast majority of the tumors, is chromogranin.
For individuals with symptoms consistent with a NET, it is useful to measure levels of 5-HIAA, a breakdown product of serotonin. The 5-HIAA test is performed on a urine sample obtained over a 24-hour period. It's necessary to restrict certain foods and drugs prior to this test. Overall, measurement of chromogranin A in the blood is the best available test for diagnosis of a NET.
When a chromogranin A comes back elevated, it is not proof positive that you have a neuroendocrine tumor. It's important that one keep in mind that there are situations that can give rise to so-called false positives. So if these things are kept in mind, impaired renal function, proton pump inhibitors, chronic inflammatory conditions, and inflammatory states, then a positive or elevated chromogranin A should make one very suspicious that you might be dealing with underlying neuroendocrine tumors and pursue further testing.
So, The chromogranin A test can point toward the diagnosis of NET or help eliminate it. But are there any NETs that give a negative CGA test?
There'd be 10 or 15% that'll give a negative chromogranin A. Insulinoma is the most common neuroendocrine tumour of the pancreas, and they tend sometimes not to have a raised chromogranin A. But then insulin or parts of insulin, proinsulin or C-peptide are very good markers, so we usually do have another marker.
Measurement of CGA is mandatory for effective diagnosis and management of NETs. So if the CGA test is positive, what's the next step your physician might take?
If you are a patient and they diagnose a mass that a physician thinks it could be a neuroendocrine tumor, the first thing is tissue biopsy is fundamental, because those tumors, they have some characteristics that could define how they will progress and what I would expect in the future. This is important to define what type of therapy we're going to do. So biopsy is very important.
A positive CGA test can raise the level of suspicion that a NET may be present. The diagnosis can then be confirmed using appropriate imaging techniques and additional tumor markers. Determining the location and extent of the NET is crucial for selecting treatment. In addition to commonly used imaging techniques like CT scan and magnetic resonance imaging, there are specialized methods such as positron emission tomography or PET scans, endoscopic ultrasound and somatostatin receptor scintigraphy, or octreotide scans that can reveal the location and size of a NET.
Once we have a strong suspicion that there's a neuroendocrine tumour there, the chromogranin A is positive, then the next test that I would like to see done is a CAT scan, and then very soon after that, if there's any tumour visible, then octreotide scintigraphy, which is an octreotide scan.
The octreotide scan is the most sensitive test for detecting the presence and extent of spread of these neuroendocrine tumors. Several studies around the world have demonstrated that it is more sensitive for diagnosing the extent of spread of these tumors and identifying the primary than CT, MRI, or both combined.
I usually tell to my patients that the strategy to treat him, it starts in the day -1. So when I stage the patient, which means understand what is the amount of disease this patient has, what's the type of disease, what's the rate of progression, and the type of symptoms they produce, the tumors, then we can make the strategy of therapy.
Because the treatment of a NET depends on its location and the stage of the disease, your doctor will use all of this diagnostic information to recommend the best course of action for you. If you or a loved one has a NET, it is important to know that there are advocacy groups and patient support organizations that are promoting research and working to improve outcomes for people with NETs.
My messages today would be, you must be your own advocate. I think there are a lot of people who are going to feel very intimidated by the diagnosis of carcinoid. If you don't feel that you're able to go ahead and research it properly and get the information you need to, then you should find an advocate who'll do it for you.
I would definitely tell someone who is newly diagnosed to join a support group where they can touch base with a lot of patients that have been through something similar, maybe even different than what their exact situation is, but you can learn so much from other people that have been through this. There's a lot of resources out there that there weren't years ago for carcinoid cancer, and hearing what the experts have to say is key.
We thank all our experts and patients for their insights into the diagnosis and treatment of this challenging disease. We hope you will benefit from their experiences. For more information, please go to the NET community website. It brings together people from around the world to enhance awareness, understanding, and management of this disease. This is Richard Olden for the NET Report.